Hello, everyone. We're going to give it one more minute, see if we can get anybody else who's trying to join in, and then we'll start.
Good afternoon, everyone. My name is Ms. Gutierrez. I will be your producer for this session. If you have any technical difficulties or any questions about Zoom, please feel free to private message me and we can troubleshoot together. Thank you.
All right, we are one past the hour. My name is Adam Sorensen. I'm the nurse educator for the biocontainment unit at Denver Health. I make up what is called the HIT team, who staffs our biocontainment unit. And today for our Funky Bug presentation, we have Bill Neville, who's going to present, and I will let him introduce himself.
All right, thank you, Adam. My name is Bill Neville. I'm the Emergency Management Coordinator here at Denver Health. I've been here for 2 years now and actually started as an intern in this program, working with Jake and Adam in the HIT team to kind of go over our emergency management program and how that relates to the BCU. So today I'm going to kind of start with an overview of the emergency management program and kind of use that to look at what the organizational response to a BCU activation looks like. So first of all, our goal at emergency management is to prevent, prepare for, respond to, and recover from all hazards which might impact hospital operations. So a few key components of that program would be our emergency operations plan, and that's where we're kind of coordinating the different areas of emergency management. So things like communications, resources, utilities, and staff support, and kind of feeding that back into our sort of overall program and preparedness initiatives to make sure that we're ready to respond to emergency. We also head our emergency management committee. So that's made up of kind of key stakeholders and subject matter experts from across the organization to help guide those preparedness initiatives. We also want to make sure that all staff at Denver Health are sort of ready, comfortable, and sort of empowered to initiate a response to an emergency. So we do sort of general preparedness training for staff and then more focused exercises to make sure that we're kind of building that muscle memory so that all staff are ready to respond to an emergency. Finally, our hazard vulnerability analysis. So that's a tool that we use to try to quantify the probability and impacts of different hazards to the sort of Denver Health enterprise. So I'll get into that in a bit more detail in a moment. But I also wanted to review our tiered approach to emergency response. So there's a saying that all emergencies are local, and that's kind of represented at the base of the pyramid in green. So that would represent an emergency or a hazardous situation where within your department, you have the sort of resources and ability to respond. So that could just be something like there's smoke coming from the microwave in the break room, and you're able to sort of continue with your operations, maybe unplug the microwave, open some windows, close the doors, that sort of thing, so that you're able to continue with your operations. Oops. Above that is what we refer to as an escalation. So basically that means that due to the scope of the event, you're reaching out to other departments to support you in your response. So that could just be calling security, calling engineering, something like that, to help you with the response. And above that is our organizational response. So that means that, again, due to the scope of the problem, we want to make sure that we have sort of the full support of the organization behind the response. So we're activating incident command and we're filling those incident command roles. And lastly, above that is our organizational and external response. So same thing, we're activating incident command, but we're also cooperating with external agencies, whether it's state or local law enforcement, something like that. So something that I kind of like to stress when we give these sort of general preparedness trainings is that any staff member, in your day-to-day work at Denver Health, you might be the first person to encounter a hazardous situation or an emergency situation. But we've kind of built this framework to make sure that you're not on an island and that you have the full support of the organization to respond to whatever that situation is. And that's kind of a theme that I'll want to revisit once we get to the BCU activation. All right, so this is a look at our 2023 Hazard Vulnerability Analysis, or HVA. So you can see along the left, we have our list of different hazards or events. And then as you work your way across, we're trying to quantify the likelihood that that event will occur, impacts to safety, to physical infrastructure and services. And then we balance that against how prepared we think we are to respond to that event. And that all gets kind of factored into the overall score on the right in yellow. So every year we review this document, we bring in what we call hazard champions to sort of help us review any changes or any sort of updates that we want to make to these scores based on events from the previous year or sort of any other changes to our plans. So for example, at the top, we have avalanche. Year after year, our hazard champions assure us that those do not occur on the Denver Health campus. They haven't been proven wrong yet, so that gets 0 or NA across the board. You can see at the bottom that we have special pathogens kind of listed under emerging infectious diseases. So we can say that there's a moderate likelihood that that will occur, probably due to our status as a regional treatment center. And then looking at the preparedness, you can see we have kind of high scores across the board there, in large part due to the work that the HIT team has done to make sure that we're prepared to care for those patients. We also, specifically with the internal and external response, a lot of that comes down to the work that we've done sort of in cooperation with the HIT team, working on our response. And one last thing for the HVA, so we use these scores in this document to kind of guide us to make sure that we're allocating time and resources over the next year most effectively based on those scores. So what does that work look like in relation to the HIT team? So I'll start with our special and emerging pathogens response plan. That kind of takes us from the beginning to the end of what our response to sort of caring for a special pathogens patient looks like. You can see that that falls kind of under the umbrella of our enterprise emergency operations plan. This is a hazard-specific plan with more of a tactical focus. So we're kind of looking at those sort of direct actions that need to happen in order for us to respond. You can see on the right, we have, that's a look at our EM pulse site with some of the other hazard-specific plans, so things like utility interruptions and failures and no-notice events. We also want to make sure that we are practicing kind of all of those components of that special pathogens plan. So we might do kind of more targeted drills, like communications drills and the Ask, Isolate, Call mini drills that we did last winter, where we're sort of practicing very specific components of that plan. We'll also do tabletop and functional exercises where we're kind of looking at the full plan, sort of getting practice responding and bringing in a wider range of stakeholders, including those regional and external partners. Finally, we have our high-risk pathogen notification algorithm. So that kind of outlines our communications plan from the beginning with a suspected high-risk pathogen patient and those sort of initial steps that we take to bring together the HIT team and other stakeholders. So today I'm going to use this to kind of walk through what our overall enterprise response would look like. So starting at the top, we have a patient, and I'm going to steal the scenario that we used a couple years ago for an exercise over at the Lowry Clinic. So we have a patient who walks into the Lowry Clinic, they describe their symptoms and their travel history to registration there. And that should kind of alert registration staff there that this might be a suspected high-risk pathogen patient. So they reach out to the ID attending. The ID attending will sort of get more information. They might talk directly to the patient over the phone just to kind of assess that information, and then turn around and reach out to the EM on call. So that's either me or my boss, Emma, and say, we do need to get this, what we call the phase 1 group together to make a decision about admitting this patient. So when we get that call from the ID attending, we'll send out a rave notification to that first group that you see there. Basically, they get a message that says, due to a suspected high-risk pathogen patient, please join this WebEx call in 15 minutes. So once we get that group together onto a conference call, the ID attending will give a quick status update and risk determination for the patient. And then we kind of work through the activation criteria that you see at the bottom of the page there. So this is the actual script that we have for this phase 1 call. And we just kind of want to make sure that we are taking the effort to assess those different criteria you see at the bottom. So things like PPE requirements, waste management requirements, and any potential media impact. So that we want to factor all of that into this decision, whether or not we are going to admit the patient to the BCU. So the point of this call is, again, to get this group together just to make that decision. So when we end this call, we should know whether or not we're admitting the patient. For today, I'll just say, yes, we are going to admit this patient. And then I'm going to quickly hand it over to Adam. So I just want to give some context. Once we end this call, once we make that decision, on the EM side, we have our next steps, but I want to let Adam kind of go through what the HIT team is up to at this moment.
Yeah, thank you, Bill. What the HIT team would do next is see if we have any staff on the team currently staffing in our units, and then try to work to backfill them so we can pull them over to the biocontainment unit and get prepared to receive the patient. At that time as well, we'll be sending out a rave alert to all team members to notify them of a activation, and then to see also who's available or willing to come in to help set up our biocontainment unit and or staff. And then from there, we'll start working on a staffing plan for prolonged activation. And on top of that, there would be quite a few communications with different areas throughout the hospital to help us, because our biocontainment unit is regular patient care. So there is some requirement for moving equipment around or setting up. So start initiating that process as well. Back to you, Bill.
Cool, thank you. So at that point, we kind of have our next steps. So we'll be, again, we've made that decision to activate. So our next step would be to reach out to this phase 2 group. So that's kind of, again, a much wider scope of participants, basically everyone who would be involved in activating the BCU. So again, they get they get a rave notification asking them to join a WebEx call where we will go through this script. The ID attending, again, gives a status update. This time we'll have someone from the BCU there to give us another update on that sort of activation progress. So everything that Adam was talking about there, or any sort of needs that they might have. And then we go through this roll call. So all the departments that are represented in this group will go through a brief overview on their steps to support activation, and also kind of have that opportunity to let us know if there are any sort of additional needs that they might have. And quickly back to Adam. So at this point, we are sort of moving along with that activation process. We're thinking about patient transport if it's necessary. So if we need to get that patient from Lowry to the main campus, and patient care. Adam, is there anything that you wanted to kind of add for that step?
Yeah, at this point, this is kind of the physical side of things where things are really starting to move now because you guys have contacted and coordinated with everybody who's helping move and set up the biocontainment unit. From there, it's communication with who's going to be staffing the biocontainment unit, and then also following back up with you guys on ETA for Denver Health paramedics to pick up the patient, arrival, things like that, gathering more information on the patient if there is any more for anticipation of what might be done, and also communicating with like our lab team and things like that on uh, helping set up that end of things as well. Um, but the big thing is here is we're just making sure the physical rooms are all set up, ready to receive the patient, double checking everything, and based off of things we've gotten from and learned from emergency management, we have job action sheets that we can hand out to anybody, and it just explains exactly what to do, like move all the chairs from here to there type of thing. So anybody can help if they're willing and able to.
Great, thank you. Okay, so at this point, after that phase 2 call, generally the AOC, the administrator on call, would huddle with the emergency management on call, PR on call, and the ACC. So during sort of any other type of event, we've kind of made this emergency response algorithm to help the AOC kind of assess the situation and decide what the needs are to manage the incident. So specifically kind of coming to that decision of whether they need to activate incident command and the hospital command center. In this case, everyone on that huddle was already involved in the phase 1 and phase 2 calls. So we have sort of a pretty good grasp of what the needs will be and sort of what the anticipated impacts to Denver Health would be. And I would be pretty confident in saying that we would recommend activating incident command. So jumping back to the tiered response pyramid. So again, this would be sort of an example of an organizational response. So we're activating incident command and filling those command roles to make sure that we are ready to support the BCU activation as an organization. So this will sound familiar again, but at this point, in order to activate incident command, the EM on call would send out a rave notification, again, this time to the incident command team group. So that's, I think about 100 people would be getting this message that's saying, please hop on this conference call in order to support the BCU activation. So at that point, the AOC would walk through their sort of initial report out, sort of explaining the reason that we're bringing this group together, why we decided to activate incident command, and give that current situational assessment. Then as a group, we would identify objectives for incident command, do that sort of roll call, report out again, and then start working to identify the specific job responsibilities and assigning incident command team members and roles. So what is the purpose of getting this group together? So really we want to ensure that we are supporting the BCU activation as effectively as we can. So we're getting this group together to respond rapidly to an incident requiring attention. So we kind of have this group of roles and staff with that decision-making authority to respond effectively and quickly, also to problem solve for anything that we might expect, or something that we did not expect, anything that we hear from the BCU team. We also want to kind of break down silos and roadblocks and make sure that we're responding as a team. So basically we have everyone at the table ready to respond to whatever the BCU needs. So what is an incident command team? So again, those are these key stakeholders with decision-making authority. They're going to implement command and control needed for the logistical, fiscal planning, operational and safety considerations for an incident. The AOC, so they've been on all of those calls so far, they're stepping immediately into that incident commander role. And kind of the first step there when they're starting to look at who's going to be filling these roles is looking at the command staff. So that's made up of the public information officer or PIO, the liaison officer, safety officer, and the med tech specialist. And they're sort of responsible for maintaining the overall management of the incident, setting those incident objectives and priorities, and devising and improving strategies. So in our special pathogens plan, we have kind of recommendations for who would fill these roles based on those sort of initial operational period tasks that they might be responsible for. So for example, the public information officer, there's going to be need to draft internal messaging to staff on-site and those off-site. Also, messaging might be necessary externally for patients and families. And then also providing external updates to media outlets and for our own social media presence. So for that role, we would suggest someone from public relations and communications, probably that PR on call that was already sort of briefed and part of that discussion earlier. Another thing I want to highlight here is the liaison officer. So they're going to be working with outside agencies, stakeholders, and organizations, and basically coordinating with them and public health agencies to support that response. So usually we would have someone from the Denver paramedics fill that role. We also have the med tech specialist, and whatever the specific incident is, that's going to be someone with subject matter expertise on the specific hazard. So in this case, we would have an ID physician take that role. All right, so then moving on to our general staff at the bottom here. So that includes the operations section chief, the planning section chief, logistics, and finance. So operations, those are kind of the doers for these responses. So we might put someone in that chief role who is a nursing director or someone with that, or the ACC or something like that. So for example, we might have Kelly Madero fill that initial role. So then for this response, basically everything happening at the BCU, and then if the paramedics are involved in transporting a patient, they also sort of fall under the operations section. So we might assign a BCU branch director and an EMS branch director. And then any needs or updates that they have will come up sort of through that structure to the operations section chief. So if there's, for example, if we're running short on some sort of critical supply of something, then that might come up through the operations section chief, and then Kelly will reach out to the logistics chief. So logistics, that's kind of the getters. So any sort of supplies or any sort of other critical supply that we need, they are going to be sort of tasked with finding that. Planning section chief is pretty straightforward. Again, kind of taking what it sounds like, sort of putting our plans and making sure we're sort of able, we're looking ahead and able to sort of achieve those objectives that we laid out. Depending on the sort of length of an activation or what we're expecting from this activation, we might also assign a training branch director and an HR branch director. Finally, we have finance, and they're the ones that are tasked with asking the question, how are we going to pay for this? Making sure that we are kind of keeping that appropriate documentation and keeping track of all those expenses. All right, so I just kind of want to revisit the idea that we're sort of, again, putting together these teams and filling out these roles so that we can sort of support the BCU, support the HIT team as effectively as we can for as long as they need it to. So we'll, during that initial meeting, kind of talk about what we want our operational period to look like, and also the kind of the criteria that we're looking for before we start demobilizing. So it's, if the patient is here for 60 days or something like that, we'll kind of talk about what that looks like to make sure that the BCU has that support throughout their activation. All right, so I know I kind of blitzed through a lot of that information. Does anyone have any questions or anything that they wanted to clarify or go over? All right, well, thank you so much for having me today. And I'm going to turn it back over to Jake and Adam.
All right, thank you, Bill. Appreciate you presenting on HICS and what a incident command looks like. I do have a question for you. It's given past experiences, how long do you think it would go on for, say, a patient with Ebola? Would you anticipate having that go throughout the hospitalization of the patient?
So that would be, I would say probably yes, just because we want to make sure that, if something, we're bringing this group together so that we sort of have that flexibility to respond to any needs that the BCU has. So we wouldn't want to sort of demobilize before we know that, we're completely ready to. So that's something that would be that the incident commander and that sort of incident command team would definitely take into consideration when they're deciding on their operational periods and what they expect that to take. But I can see, a situation where if the BCU is activated, if we're taking care of that patient for weeks and weeks, then we might run into problems that we might not have been able to sort of see coming when we initially activated.
All right. Thank you for that. All right, and that concludes this month's presentation for Funky Bugs. Next month, we'll have a Funky Bug presentation and send out information on what will be presented on. Thank you, everybody.
Thanks.